We routinely give medications in the hospital that are, biologically speaking, highly controlled poisons.
Oh, absolutely. It's wild when you really think about it.
Right. And the craziest part about traditional oncology pharmacology is that these drugs, they have zero ability to tell the difference between a rogue tumor cell and, the healthy cells in a patient's hair follicles or stomach lining.
Yeah, the collateral damage is just staggering.
It really is. And honestly, looking at a list of these medications for the first time, it can feel like trying to read a foreign language while actively running a code.
Oh, I mean, it is so intimidating for nursing students and new grads. You're just staring at these massive lists of complex generic names and toxic side effects.
High-stakes administration protocols, all of it. But I promise you, by the end of this discussion, the bedside logic behind every single one of those side effects is going to completely click.
Yeah, because once you pull back and look at the actual biological why and how on a cellular level, the need for rote memorization just falls away. The nursing interventions suddenly make perfect sense.
That is exactly the goal for today. So welcome to this episode of the Super Nurse Podcast, which is created by Brooke Wallace.
Right, and we should mention that Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author.
Yes, she is. Now, to be fully transparent, we are not Brooke Wallace, but this entire conversation is built directly from her bedside knowledge, her clinical notes, and her signature teaching style.
Our mission here is really to help you bridge that gap between textbook theory and real-world patient care. We want to help you become the kind of nurse who anticipates problems before they even happen.
Exactly. And before we get into the actual mechanisms, a quick reminder to invite you to subscribe and watch the incredible comic book-based video version of this episode.
Yeah, you can find that on the YouTube channel Super Nurse Comics, and the link is right in the description.
So setting the agenda for today, we are stripping away the confusing jargon of cancer medications. We want to break down the biological why behind those brutal side effects.
And map out exactly what clues you need to look for at the bedside, right? To keep your patient and yourself safe.
Totally. But before we can even understand how the meds work, we have to understand the enemy we're fighting.
Right. We have to know why the patient looks the way they do when they first arrive on the unit.
So let's start with a baseline of just normal human biology.
Yeah.
Normally, our cells follow a very strict set of social rules.
Yeah. They divide when they're told to, and they stop dividing when the tissue gets too crowded.
Right. That's called contact inhibition.
Mm-hmm.
And, when they get old or damaged, they undergo apoptosis, which is programmed cell death.
They essentially fall on their swords for the good of the body.
Which is very polite of them. But cancer cells, on the other hand, they are manipulative rule breakers.
Oh, completely. They just ignore the chemical signals telling them to undergo apoptosis. They literally refuse to die.
Right. And to sustain that rapid out-of-control division, they utilize this physiological process called angiogenesis.
Which is so creepy when you think about it. They force the body to build brand new custom blood vessels that route directly to the tumor.
Yeah, building their own vascular highway. So the tumor can just siphon off the body's glucose and oxygen.
It completely prioritizes its own growth over the host's survival.
And that translates directly to our bedside assessment, right? Because if the tumor is this massive parasitic metabolic drain, one of the biggest initial red flags we see in clinical practice is unexplained weight loss.
Yeah, cachexia. The patient might actually be eating normally, but they're dropping pounds rapidly because the tumor is just stealing all their fuel.
Exactly. And the evidence tells us to look really closely at changes the patient might dismiss as normal aging, which brings up a critical nursing keyword, and that is persistent.
Persistent. Yes, that is such an important concept, like a persistent cough or persistent indigestion.
Or a sore that just won't heal. In nursing, persistent means a symptom is refusing to resolve despite time and standard interventions.
I always try to emphasize that when looking at case studies. If a cough won't go away after, say, 2 rounds of antibiotics and weeks of rest, your diagnostic logic has to change entirely.
Right. You have to stop thinking about a simple bacterial infection and start wondering, well, what is persistently irritating that lung tissue from the inside?
And when investigating that, oncology generally categorizes cancers based on where they started. The 2 main ones we see at the bedside are carcinomas and sarcomas.
Right. So carcinomas are the most common, right? Like 80 to 90% of all cases.
Yep. They start in the epithelial tissue, which is the lining of the internal and external surfaces. So think breast, colon, prostate, or lung cancers.
Got it. And sarcomas, meanwhile, they originate in connective tissue. So like bone, muscle, cartilage, or fat.
Exactly.
Okay, let's ground this in a practical application for the bedside.
Right.
In clinical reports, we often see the T&M staging system used, tumor size, node involvement, metastasis. So if a bedside nurse is assigned a patient with a massive invasive colon carcinoma, let's say a T4 tumor, meaning it's grown completely through the bowel wall, how does that pathology change the nurse's physical assessment?
Well, it immediately shifts the nurse from routine data collection into this highly proactive surveillance mode.
Because you're anticipating the complications.
Exactly. If there is a large invasive mass in the colon, your immediate concern is the plumbing. You have to hypervigilantly assess for a mechanical bowel obstruction.
So you're listening intently for those hyperactive, high-pitched bowel sounds that suddenly go absent.
Right. And you're checking for a rigid, distended abdomen or severe cramping. You're anticipating that the tumor is going to block stool transit before it becomes a full-blown surgical crisis.
That makes so much sense. So if we know that cancer cells are defined by this rapid, out-of-control division, the pharmacology actually starts to make a lot of logical sense.
It really does. Traditional chemotherapy is designed specifically to target and destroy any rapidly dividing cell in the body.
Just a blunt instrument.
It is. It's cytotoxic. The fundamental flaw of these order drugs is that they lack a targeting mechanism. They can't tell the difference between a rogue lung cancer cell and a totally healthy, fast-growing cell.
And that biological mechanism is the exact reason we see such distinct collateral damage at the bedside.
Yeah.
The drugs just hunt for cellular division.
Right. So any tissue in the body that naturally replaces its cells quickly gets caught in the crossfire.
Like the hair follicles, the lining of the GI tract, and of course the bone marrow.
Yeah, the bone marrow crash is a massive priority for nursing care. Since the marrow is the factory for our blood cells, chemo suppresses it severely.
Which leads to neutropenia, anemia, and thrombocytopenia.
Yeah.
And the bedside numbers really dictate our interventions here.
They absolutely do. Take thrombocytopenia, which is a dangerously low platelet count. When platelets drop below 100,000, the patient is at a high risk for spontaneous bleeding.
But the most immediate life safety threat is neutropenia, right? That severe drop in neutrophils.
Yes, that is the big one.
I actually used to think the rule against allowing fresh flowers in a neutropenic patient's room was just like an old hospital wives' tale about allergies or something.
A lot of people think that, but looking at Brooks' clinical notes, it's entirely about fungal spores.
It's a strict infection control measure.
Because neutrophils are the immune system's frontline infantry. Chemotherapy obliterates the bone marrow's ability to produce them, so the patient has zero frontline defense.
So those microscopic fungal spores on flower petals or bacteria in the vase water, they become lethal threats.
Exactly. And without neutrophils, there's no localized inflammatory response to contain an infection, which completely alters how we view vital signs.
Right. In a healthy person, a temp of 100.3 Fahrenheit might just mean a mild cold.
But in a neutropenic patient, a fever of 100.3 is an absolute deadly emergency.
You need immediate blood cultures and broad-spectrum IV antibiotics. We do not wait an hour to see if it comes down.
No, you act immediately. And, if chemo is harsh enough to wipe out the bone marrow, it's doing the exact same thing to the epithelial lining of the GI tract.
Right, which triggers those massive GI side effects, especially nausea and vomiting.
Yeah, because as the dying cells in the gut break down, they release serotonin, which directly stimulates the chemoreceptor trigger zone in the brain.
And a major pitfall for newer nurses, I've seen this happen, is treating chemo-induced nausea like standard postoperative nausea.
Oh, waiting for the patient to hit the call bell or complain or even start vomiting before fetching the antiemetic.
Right. But waiting for the vomiting cycle to start means that chemical cascade is already in full effect, and it is incredibly difficult to break once it begins.
The evidence-based standard for oncology is proactive administration. You have to give a 5-HT3 receptor antagonist like ondansetron or Zofran 30 to 60 minutes before the infusion even begins.
To block those serotonin receptors ahead of time.
Exactly. Get ahead of it.
And keeping ahead of the GI damage also applies to the upper GI tract, specifically stomatitis or mucositis.
Yes, as the mucosal lining of the mouth is destroyed, the patient develops severe ulcerated sores. It is incredibly painful.
Now, my initial thought process used to be, well, if it hurts the patient to swallow even a sip of water, shouldn't we just make them NPO to rest the gut?
It sounds logical, right? But the clinical reality is the complete opposite. The patient is experiencing active tissue breakdown.
So they desperately need protein and calories to rebuild that tissue.
Exactly. Starving the patient actually hinders the healing process. So instead of making them NPO, the nursing intervention is to modify the environment so they can eat.
We use soothing measures, right? Like viscous lidocaine.
Yes, that thick, sticky local anesthetic. It coats the mucosa and numbs the sores temporarily so they can tolerate nutrient-dense, soft foods.
And we also have to strictly avoid alcohol-based commercial mouthwashes, like Listerine.
Oh, definitely. The alcohol acts as a severe astringent. It burns the open ulcers and dries out the tissue, which just makes the stomatitis worse.
Ouch. Yeah, that sounds terrible. And the toxicities aren't just limited to those fast-growing cells either. Some specific chemo drugs damage organs as they're metabolized.
Cisplatin is a prime example of that. It actually contains platinum, a heavy metal.
Which the kidneys have to filter out.
Right. And as they attempt to filter and excrete it, it causes direct cellular damage to the renal tubules. So there's a massive risk for nephrotoxicity.
So the bedside, if you see cisplatin on the MAR, your brain should immediately jump to renal function.
The clues will show up in the labs and the Foley catheter way before the patient feels sick.
You're tracking trends, monitoring for a creatinine climbing over 1.3 or a BUN rising above 20.
Or a urine output that suddenly drops to 30 milliliters per hour or less. Those numbers tell you the kidneys are in distress.
So if these medications are aggressive enough to destroy bone marrow, ulcerate the mouth, and damage renal tubules, we really have to consider the occupational hazard here.
We do. You need to treat chemotherapy administration with the exact same level of respect and caution as a hazardous chemical spill in an industrial lab.
Which brings us to the 48-hour rule.
Yes. Hazardous traces of chemotherapy and its toxic metabolites remain active in the patient's system, and they are actively excreted in waste urine, stool, vomit, even sweat for about 48 hours after the administration ends.
So the danger isn't just in the IV bag itself.
No, it extends to the bedpan, the soiled linens, the bathroom. Caregivers and nurses have to wear proper PPE.
Specifically nitrile gloves, right? Not standard latex.
Correct. The mechanism here is that chemo agents are chemically aggressive enough that they can actually permeate standard latex on a molecular level over time.
Wow.
Yeah, nitrile provides a denser synthetic barrier to protect your skin.
So nitrile gloves are mandatory for waste. And nurses should never touch oral chemotherapy pills with bare hands either.
Never. And those pills should never be crushed, split, or broken unless explicitly directed by pharmacy.
Because crushing them aerosolizes the toxic dust, and you could accidentally inhale it.
Exactly. And the environmental protocols during that 48-hour window are super strict. Toilets have to be double flushed.
With the lid down, right, before flushing.
Yes, to prevent contaminated water from aerosolizing into the air. And if linens or clothes get soiled, they have to be isolated, washed separately, washed twice, and in hot water.
Just to fully break down those chemical traces, with the shift toward home-based care, a lot of patients are taking complex oral regimens or using portable continuous pumps at home.
Which is why every home infusion patient gets a bright yellow spill kit.
And a major part of our nursing role is educating the family on how to use it. Like if a line disconnects, they have to double glove, use absorbent pads, and put everything into those puncture-proof yellow hazard bags.
And the crucial piece of education there is that those yellow bags must be returned to the clinic or hospital for specialized incineration.
They can never just be thrown into the municipal household trash.
Never. They are hazardous environmental waste.
So, because these IV drugs are so caustic, a lot of them are classified as vesicants, meaning if they leak out of a peripheral vein into the tissue.
Oh, it causes severe blistering and irreversible tissue necrosis. It is awful.
Which is why they require central venous access devices, like PICC lines or implanted chest ports.
Right. The physiological logic of a central line is all about dilution. Instead of pushing a caustic drug into a fragile little arm vein, it delivers it directly into the superior vena cava.
Right above the heart.
Exactly. The massive volume and velocity of blood there dilutes the chemo instantly, protecting the vessel walls from chemical burns.
And when we access those implanted chest ports, we have to use a specialized non-coring Huber needle.
Yeah, that's so important.
I always visualize a standard needle like a tiny apple core. Like when it punches through rubber, it takes out a tiny plug of material.
And if you use that on a chest port, it would permanently damage the self-sealing silicone membrane.
It would just leak chemo under the skin. But a non-coring Huber needle is sliced at an angle, so it acts more like a wedge, parting the silicone like a curtain.
And when you remove it, the curtain falls back, sealing perfectly.
Now, contrasting systemic chemo with localized radiation therapy reveals totally different nursing priorities.
It does. With external beam radiation, it acts like a highly focused flashlight aimed at the tumor.
So the patient isn't radioactive afterward, but their skin is incredibly vulnerable, like a severe sunburn.
Right, so bedside care involves strictly avoiding powders, scented lotions, or tight clothes that could cause friction.
But internal radiation, or brachytherapy, that requires a completely different mindset.
Yes. A radioactive implant, like a pellet, is placed directly inside the body cavity, so the patient is actively emitting radiation.
Meaning our nursing care revolves around time, distance, and shielding.
And you have to be prepared for dislodgement. If you're giving care and a radioactive pellet falls out onto the bed.
First rule, never touch it with your hands, even gloved hands.
Never. You use long-handled forceps to maintain distance, pick it up, put it immediately into a specialized lead-lined container in the room, and call nuclear medicine.
It's intense. But while we spend so much time managing these blunt instruments, the horizon of oncology pharmacology is radically shifting.
It really is. We're moving away from carpet bombing the body and entering the era of precision medicine.
Highly personalized genetic treatments, like tumor-agnostic drugs.
Right. Historically, a drug was approved for lung cancer or breast cancer, but a tumor-agnostic drug targets a specific genetic mutation, like the NTRK gene fusion, regardless of what organ the cancer started in.
It doesn't care if it's colon or breast tissue. If the tumor has the mutation, the drug targets that exact pathway and leaves the healthy cells alone.
And then there is immunotherapy, like CAR T-cell therapy. That concept here is just mind-blowing.
It really is. Instead of giving a chemical poison, they draw the patient's own T cells, take them to a lab, and genetically engineer them.
They give them special receptors that recognize the specific protein on the patient's tumor cells. Then they multiply them and infuse them back.
It's literally giving a software update to the patient's own immune system so it can hunt down the cancer.
Exactly. But, while these targeted therapies reduce those traditional side effects, the psychological toll of a cancer diagnosis is still profound.
Yeah. The nurse's role in managing the invisible side effects is just as critical as managing the IV pumps.
Think about alopecia or hair loss. Clinically, we just document it as an expected physical side effect.
But for the patient, it's a traumatic stripping away of their privacy. As long as they have their hair, they can choose who they share their diagnosis with.
But once it falls out, they can't hide anymore. They can't just go to the grocery store and blend in. The diagnosis is public.
And recognizing that loss of control really dictates our nursing intervention, we want to empower them to take their agency back.
Right, by encouraging them to pick out a wig or cut their hair short on their own terms before the aggressive hair loss actually begins.
It changes it from something happening to them into a process they are actively managing.
And that brings up probably the most challenging part of the job. How do we, as nurses, handle the quiet moments after the oncologist delivers a devastating prognosis and leaves the room?
You're just left standing there in the silence with a terrified patient.
And the clinical tasks, the pumps, the labs, that's the science of nursing. But holding space for a patient's grief, validating their fear, and just sitting with them in that heavy silence without offering empty platitudes.
That is the art of nursing.
It requires immense emotional intelligence. And it's every bit as essential as understanding the pharmacology.
That right there is the defining characteristic of a super nurse. The goal today was to show that when you understand the biological mechanics, why a tumor causes cachexia or why chemo triggers neutropenia and stomatitis, your nursing interventions stop being arbitrary lists.
They aren't just things you memorize for an exam. They transform into logical, intuitive, life-saving bedside actions.
You're critically applying knowledge to protect your patient.
And to add one final thought to mull over, as these genetic therapies and immunotherapies advance, we are approaching a reality where many forms of cancer will shift from being terminal illnesses into chronic, manageable diseases.
Kind of like how we treat diabetes or hypertension today.
Exactly.
And that paradigm shift is going to fundamentally change the future of nursing care. It changes patient education, how we view survivorship over decades. It's an incredible horizon to keep in the back of your mind as you step onto the floor for your next shift.
It really is an exciting time for oncology.
Absolutely. Well, thank you so much for joining us for this episode of the Super Nurse Podcast. Don't forget to check out the comic book video version of this discussion on the YouTube channel, Super Nurse Comics.
Please like, subscribe, and leave a comment to let us know what you thought.
And be sure to visit supernurse.ai for incredible resources designed specifically to help you become the super nurse you were born to be. You've got this. Keep learning, keep caring, and we'll see you next time.